Thank you very much to everyone who is here and to the organizers of the Congress. The person who knows others is informed. Those who know themselves are wise. First, let's see what others are doing, and then we'll all devise a strategy for our own patients. First, the main headings: the importance of this disease, therapeutic methods, what are resistance definitions, what are the reasons, and what can be done. Social anxiety disorder, we all know the definition. It's a fear of humiliation in social situations, also peripheral anxiety signs and avoidance behaviors. They cause competence loss. Why important? First and foremost, previously, this was perceived as shamefulness. However, after the 80s, it was included in the DSM system. Even though the disease is known well, therapeutic strategies or definitions as to resistance are not yet fully established. It's encountered 13% of the population. Comorbidity is found in 70% of such patients. Now, as you can see, the most frequently encountered anxiety disorders, it's one such disease. But consider your patients, obsessive-compulsive disorder. Do you have as many social phobia patients coming to you? So to define resistance, we have to establish healing and curing. Healing and curing, it's the absence of shame, but is the loss of anxiety a recovery for you? Ya utanç neydi? Shame deyip duruyorum. Embarrassment mı ne? You may miss anxiety when trying to look for other things. So how are we going to define this loss of competence, this loss of function? If that's predominant, you have to treat that first. There's something you have to be careful about. It's seen frequently in women. Postpartum, these people, they leave their jobs and stay at home. So you have to take note of functional loss in healing. Again, this group of disease does not heal easily. To what extent, what percentage do they get cured? 1/3 gets fully cured, 1/3 remains as they are, and 1/3 experiences partial healing. So chances of success are same as other anxiety disorders. Response to treatment: if there's more than 50% reduction in the total scale scores, we say response to treatment. For social phobia, we have a period of 12 weeks, and if there's partial response, we continue like that 4 to 6 weeks more. What should we do for social phobia? Anxiety and Hamilton depression should be 6 or 7. Sheehan competence loss is important here. There has to be 0, and in LSF scale, it has to be 30.6. You remember the social phobia scale, 24 questions, fear and avoidance. 144 is the total points. If you're 30 and less, it's remission or absence of social phobia. 60 and above is more suitable, it is said, because then percentage healing can be calculated better. Until 70 it's moderate, after 70 it's pronounced, after 90 it's severe. Now, consensus. There's in treatment and resistance, clinical global improvement scale is 1 or 2. This is absolute in all treatments, but it's according to Leibowitz social scale. In some trials, reduction is 25%, and sometimes it's 35%. Okay, then which agents are used in treatment? Now, according to category classification, you may not remember this, but until A to F, it's worsening. In A, there's a lot of studies. These are double-blind, placebo-controlled studies, and they're more superior to placebo. In B group, one or more trials which are superior to placebo or standard treatment. Trials in C are uncontrolled. D are mixed. They have good and bad results. In E, there are negative findings. In F, inadequate information. So, in pharmacological agents, they have been classified accordingly. As category, they start from 1 and go to 5. That's from good to bad. So this is how we classify the medications. SSRIs, among SSRIs, escitalopram, paroxetine, sertraline, fluvoxamine, again venlafaxine. These are first-line medications. Penelzin, not available in Turkey. This is very effective, but it has side effects, it is said. Citalopram ranks third. Benzodiazepines, from them clonazepam and gabapentin studies rank third in B category. However, maybe contrary to what we know, do you see D category prescriptions in social phobia? Fluoxetine is in D category. Now, roughly, A class is escitalopram, superior to placebo, effective, and with regard to relapse, it's good. Fluvoxamine, again, same compared with placebo. You see, in some, it's half and half. Superior to placebo in rage and anxiety, it yields better results. There are more trials for paroxetine. It takes predominance in comparisons, again, in alcohol and substance use. If there's concomitant depression, high dosages are effective. Same for sertraline. To summarize, SSRIs are first-line treatments apart from fluoxetine. Effect emerges as of 6th and 8th week, but wait until week 12. Only 50% healing can be observed. Full healing may be longer than that. Venlafaxine is an A group medication. In studies in SSRI non-respondent patients, you may increase the dosage, and 83% response can be obtained in paroxetine venlafaxine placebo comparison study. With regard to effect and side effect, paroxetine and venlafaxine showed no difference. However, contrary to what we know, we say paroxetine starts fast. By the second week, venlafaxine was shown to be more effective. This is a Leibowitz performed trial. Moklowitz. In some trials it's superior, in some not. In USA it's no longer used. In meta-analysis trials, its effect is lower compared with SSRI. What else do we have available? Benzodiazepines, again in anxiety disorders, clonazepam emerges to the foreground. As good as paroxetine, results-wise, alprazolam is more superior to placebo, as effective as BDT. However, relapse rates are higher when compared with phenelzin. It is as effective as phenelzin, it is said. Beta blockers are not in widespread use, but not many significant results. Pindolol, paroxetine augmentation did not yield significant results. Mirtazapine C group, gabapentin B, pregabalin D, olanzapine C. When olanzapine is in C, the quetiapine study did not yield significant results. It was classified in E group. Buspirone is not used by itself, but in treatment-resistant cases, it's better. It's been observed. It's added to SSRIs. Sometimes a different color may beautify the picture. Therapy, pharmacology, if they go together, what happens? Phenelzin is an A group medication. Its comparison with BDT, phenelzin is superior. However, relapse rate is higher. Later on, in the BDT group, phenelzin placebo and educational support group, in those groups, group therapy and phenelzin have been shown to yield more effective results. Fluoxetine, you'll remember, it was a D group medication here as well. 5 groups have been separated, and when you look at the rates, BDT and fluoxetine taking group, its response and healing rate is a bit higher. Sertraline is A group. I wonder, is that why it's better with the sertraline group? And moclobemid was the B group. As you remember, 3 months later, the medication taking group gets better, but no significant meaning after 6 months. In new studies, the cycloserine exposure studies have yielded successful results. Okay, so what to do in case of resistance? What do we have available? First of all, it has been explained. I want to go a bit fast. Do we have the correct diagnosis? Do we have the correct treatment? Do we have suitable dosage and suitable time frame? Has therapy been added? Are there concomitant diagnosis, comorbidities? Are there other underlying medication use? Secondary gains? So these will help you in deciding whether or not there is resistance. Who gets these the most? If onset signs are severe, if treatment starts late, if there's alcohol substance use, if there's social phobia history in the family, and if there's personality disorder. Now, about resistance, it's as if we think it's as if we know a lot about anxiety disorders, but there's very few studies on resistance. For instance, one of those is the case report study conducted on 10 patients. The medications used, and they all have comorbidities. Healing is the chronic global healing after phenelzin use. It is known to come down to 1. There's another study, 60 milligram or more paroxetine treatment for 12 weeks. It's a longer period. And the Lebowitz social phobia scale, there's not more than 35% reduction. Consensus continues here as well. Clinical global improvement scale, if it's not 1 or 2, resistance is there. And after escitalopram, you see more than 35% reduction. Only, as you can see, healing only starts by week 6. We have to wait. Okay. What categories do we have in resistance? You see other medications here, no tricyclics. These are the effective ones, as you can see. Levetiracetam, Trotimans, Tiagabin. In resistance, there's studies about venlafaxine, SSRIs, buspirone interaction, or escitalopram trials are effective trials. Now, SSRIs and SNRIs rank first, second, difficult to tolerate ones, third, in treatment-resistant cases, benzodiazepines, clonazepam, if there's no addiction history, that is. Again, escitalopram and gabapentin are third category medications, olanzapine, traniciprolene, tiagabin, topiramate, and levetiracetam. There are studies conducted with these, but they are found to be effective, but we need controlled studies. Again, in resistant cases, SSRIs, buspirone should be added to SSRIs. It's effective. Non-pharmacological studies, BDT and exposure. Some studies are effective, some are not fully effective. Therefore, they are D category. Again, these cycloserine studies are the same. Sometimes, even if there's only one way, you can separate into 2. First treatment may be SSRI and BDT. Second is combined treatment. Third is phenelzin. Is recommended. Phenelzin is a bit more predominant for social phobia. Partial response to treatment or residual signs, psychotherapy should be added. It is said if there's no response to SSRIs, what shall we do? SSRIs, and depending on comorbidities, benzodiazepine, beta blocker, anticonvulsions, venlafaxine, atypic antipsychotics, or buspirone combinations may be done. If you get no response still, more combined treatments, SSRIs, SNRI, GABAergic, and atypic antipsychotics can be used all together. Thank you very much. Hopefully, you will treat resistances